Ladies and gentlemen, this tiny mosquito is burdening our healthcare system. Dengue every year causes 400 million infections. It leads to 500,000 hospitalizations and more than 20,000 deaths every year. Dengue can be challenging to diagnose, and the burden is likely to be higher than reported. Due to air travel, rapid urbanization, and climate change, dengue has now reached some of the areas which were previously low transmitted areas, like southern part of US, downtown Tokyo, Portugal, and France. Dengue continues to infect our health system. And there have been cases from all over the world. Dengue is affecting people of all genders, all ages, and different socioeconomic status. And ladies and gentlemen, dengue becomes even more challenging when we have two lives at risk, life of a mother and life of a fetus. So I'm going to talk to you today about a pathway to new challenge, which is dengue in pregnancy. We all know that dengue affects all age groups, but if we specifically look at the data, dengue is usually a disease of young adults. And people who are in the age bracket of 20 to 39 years of age, they are the highest struck by the dengue. And this is exactly the same age, which is the childbearing age. And some of the data shows that female in this age group are more affected than men, making them more vulnerable to this infection. So being a disease of young with the population growth, increasing number of epidemics all around the world, and broader geographical distribution, we have now increased number of dengue cases in the pregnant population as well. So dengue in pregnancy, is there a cause for concern? It definitely is, because the outcome of dengue in pregnancy has been worse if we compare it to the rest of the non-pregnant population. There might not be problems with the fetus itself, but there are problems with the fetal-maternal unit, leading to low birth weight and miscarriages and maternal death. There are so many constellation of different problems which we can encounter if we have dengue in a pregnant female. And exploring the adverse outcome, this study by Brar showed that there is a latency between infection and a preterm labor of less than 1 week in 55% of the population. So if pregnant females encounter dengue, they have more chances of going into a preterm labor. And this also becomes an indication of cesarean section, and mainly the indication is due to fetal distress, which is reported to be in the 43% of the pregnant females who are suffering from dengue infection during their pregnancy. So a systemic literature review, which was conducted in 2010 and included 30 publications in dengue virus in pregnant females, showed that the maternal infection by dengue is a significant risk factor for pregnancy outcomes in an adverse way. So dengue infection can not only be associated with higher maternal, but also perinatal mortalities. And therefore, we need admission and timely disease management in infected pregnant women, because this is of utmost importance to save the life of the mother and the fetus. And there should be a rigorous control program specifically designed for pregnant population, and it should be implemented. If we look at the risk, especially maternal mortality in dengue virus infection during pregnancy, that above the background risk, the maternal mortality in dengue fever has been reported in the literature to be 3 times higher. And if I share with you the data, the maternal mortality with DHF, my ladies and gentlemen, is 450 times higher, making it a very, very serious challenge and a problem. So whenever we talk about pregnancy, we know it is a physiological phenomena, but there are lots of physiological changes which are going on in the body of the mother. And there are special considerations in pregnancy because of these physiological changes. We know that there are changes in the respiratory system in which there is increased minute volume, increased carbon dioxide blown off to facilitate oxygen and carbon dioxide transfer to fetus. In the cardiovascular system, we have peripheral vasodilatation, decreased cardiac output, and in stroke volume. And And similarly, in the kidneys, in the pituitary hormones, thyroid, and GI, there are all changes which are physiological changes which are going on during the pregnancy period. But if we specifically look at the hematological changes, we know that there is increase in the plasma volume by 50%. The platelets are decreased in most of the pregnancies. The white cell count is usually higher with the leukocytosis, and there are increased fibrogen and factor VIII levels. This makes pregnancy a hypercoagulable state. And we all know that the chances of getting a DVT and pulmonary embolism, they rise once a pregnant female has it. So the physiological changes in the pregnancy that we encounter can mimic many of the issues and then can hide many of the problems, which can then present as a diagnostic challenge. For example, we all know that the baseline heart rate during pregnancy rises. So we can miss the rise in the heart rate due to hypovolemia or shock. Similarly, because of the growing uterus, it is difficult to detect the third spacing of the fluid. And there is edema, particularly in patients having eclampsia. So it is difficult to diagnose in which phase of patient is in overload or if patient is euvolemic. Also, we all know that in pregnancy, we have a wider pulse pressure, and the hematocrit is decreased because of hemodilation in the second and third trimester, so making our diagnostic challenge more difficult. So some of the findings which the literature has showed in pregnant females during pregnancy with dengue infection is that in the pregnant women, we all know that dengue presents in a similar pattern with fever, vomiting, muscle pains, and aches and headache. But there can be severe thrombocytopenia, there can be hemorrhage or hypovolemia, which can be life-threatening to these patients. Then we have fetal monitoring abnormalities, oligohydramnios, which is a very ominous sign, and it can lead to premature delivery and maternal death with a reported case fatality rate of about 16% in pregnancy and dengue infection. Similarly, on the fetal side and on the placenta, we know that there can be placental pathology with dengue, which includes deciduitis, choriodeciduitis, villus necrosis, and so many other things. The viral antigens are also detectable in fetal organs and placental tissue, that is the trophoblast, the villus stroma, and the decidua. So the inflammatory mediators, which are actually responsible for the cytokine storm, they're also seen in lungs, spleen, brains, and placenta as well. So this is also one of the things that we need to know before we go on to managing these patients. And the spontaneous abortion rate during first and second trimester has been seen to be higher in patients who have infections, particularly viral infections like dengue during pregnancy, and it can also lead to intrauterine or neonatal death. So what is that we can do to save the lives? And the life is not one, ladies and gentlemen, the lives are two. That all pregnant women suspected with dengue should be admitted for proper management, because every pregnancy is a precious pregnancy when it comes to dengue. So there are a few things that we need to monitor, which need further evaluation. Specifically, if we look at the heart rate, if patient has tachycardia with a resting heart rate of more than 100 beats per minute, and that is in the absence of fever, we should warrant further evaluation that why is there a tachycardia. Similarly, narrowing of pulse pressure, pulmonary edema alerts, and blood transfusion alerts are somewhat different in pregnancy as compared to the non-pregnant population. The clinical caveats that we encounter first is the hypovolemia, which may be masked even with significant blood loss. And then the third spacing. As I told you in the beginning, it is difficult to assess because of the rapidly growing size of the uterus. And dengue shock syndrome in pregnancy. The intense thirst may not appear, and the normal urine output may persist even in the shock because of increase in the volume during pregnant patients. Interpretation of the lab is also challenging when it comes to pregnancy. In the hematology, we should always rule out any pregnant female with fever and thrombocytopenia for dengue. The hematocrit, we all know that with the plasma leakage, it rises, and this is a good indicator of showing a critical phase of the disease. But in dengue, this may not be a very good sign, and a hematocrit of even 38 to 40%, which is otherwise read as normal, may indicate leaking in DHF. And we all know that there is leukocytosis as a normal physiological phenomena in pregnancy, But in dengue, we have leukopenia. So a leukopenia can be absent in the presence of a dengue infection in a pregnant female. And in that cases, a downward trend of WBC is important if we do not have leukopenia per se. And then there are markers of disease severity like albumin and cholesterol that we usually check during the critical phase as indicators of leakage, but they are not a good indicator in case of pregnancy with females. So there are some of the things which are challenging to identify to label a patient as in DHF or DSS during pregnancy. One of them, as I already discussed, is a heart rate. We all know that the normal heart rate is between 60 to 90. We have tachycardia in compensatory dengue shock syndrome, but in decompensated dengue syndrome, there is either bradycardia in the late shock or there is severe rise. But in pregnancy with dengue shock syndrome, the baseline rise is already 10 to 15%, and this can mask the early detection of tachycardia. Secondly, capillary refill time, which we all know is a marker of compensated shock and decompensated shock. This has to be evaluated carefully as well in pregnant patients. In shock patients, we all know that the peripheries become cold and clammy, but in pregnancy, there is palmar erythema due to vasodilatation and the peripheries are warm, and they can mask this sign in pregnancy as well. Similarly, we have bounding pulses, peripheral pulses in pregnancy. There is 30% rise in the blood volume and 10% rise in the stroke volume. And the appearance of weak pulses, which we take as a parameter of a shock in a normal patient, may become a late feature in dengue shock syndrome in cases of pregnancy. Blood pressure, we always take the narrowing of the pulse pressure as an indicator of shock, but the diastolic blood pressure is already very low in pregnancy, and 30% fall in the vascular resistance. So it masks early rise in the blood pressure. So similarly, these are the things that we need to look for whenever we are dealing with the case of fever and thrombocytopenia in a pregnant female. There could be other viral infections. There could be gestational thrombocytopenia, a well-known thing. Then immune thrombocytopenia, preeclampsia, very commonly encountered in pregnant females, HELP, which is hemolysis, elevated liver enzymes, and low platelet count, a phenomena commonly known to depict the pregnant females. And then acute fatty liver of pregnancy, having a high levels of transaminases, which is also seen in dengue infection. And then microangiopathic hemolytic anemias in the form of hemolytic uremic syndrome or thrombotic thrombocytopenic purpura, which is present in some of the dengue-associated pregnant cases, and other autoimmune diseases which also present with thrombocytopenia. So all of these should be kept in mind whenever we are dealing with fever and thrombocytopenia in a patient who is pregnant, apart from dengue as a differential diagnosis. Coming on, is there a difference in managing a patient of dengue who is pregnant as well? Well, there are no major differences, but we need to be more vigilant in our monitoring. We should hourly monitor the vital signs of the patient. The signs of hypovolemic shock and fluid overload must be vigilantly documented, and patient should be catheterized to know for the urine output hourly, and we should be aiming for a good urine output of 0.5 ml per kg per hour. But in addition to this, the regular monitoring that we do in the dengue patients, especially during the critical phase, these patients have to be scanned daily, not only for ultrasound abdomen for any fluid leak, but also an obstetric ultrasound for the fetal well-being. And the fluid mainly remains the same with the fluid therapy, which is then dynamic according to the pressures of the patient and parameters of the patient. But there are a few things that are very important and hallmark in the management of dengue during pregnant females. First, we should avoid induction or C-section, induction of labor during the critical phase, because this increases the mortality to many folds. And strict monitoring of the pulse pressure and urine output, specifically if patient is suffering from dengue and is in critical phase of the illness. So I would like to summarize by saying that the keys to a successful management of a pregnant female with dengue is high index of suspicion, then early diagnosis, timely admitting these patients for close monitoring and intervention if required, and keeping in mind the considerations of physiological changes of pregnancy, which can mask many of the effects of shock. So we should all be meeting the challenges head on and maintain normothermia and adequate hydration. And because oligohydramnios is an ominous sign and it is associated with high mortality, fetal mortality. So we should be encouraging the patient for oral rehydration, which can be either in the form of juices or ORS, and about the delivery. Whenever a pregnant female with dengue infection is encountered, the delivery should be avoided in the critical phase. It should be delayed or postponed, and we might need tocolytics for this. But if the delivery is inevitable, and then we should anticipate bleeding, make measures for grouping and cross-matching early, and monitor closely. And we must make sure that the patient's platelet count is at least 30,000, ideally above 50,000 before the induction of labor or cesarean section. The mode of the delivery in pregnant females with dengue is actually the preferred method is vaginal delivery. But if we have to undergo a C-section, this is on the obstetrical indication, and this has to be decided and conducted by a consultant obstetrician, and with special mentioning that they should minimize the trauma or injury to prevent the bleeding of the patient. And during the delivery, there should be continuous electronic fetal heart rate monitoring, and the partogram for progress of labor should be documented in the form of chart. So we have to have lower thresholds of transfusion in patients with dengue in pregnancy. We need to have cross-match and save the blood and blood products early. Platelet concentrates might be needed, especially they need to be transfused ahead of the delivery or during the critical phase if the delivery is inevitable. We can also give fresh whole blood or packed cell volume if there is significant bleeding. And mind you, the bleeding is significant in pregnancy if the blood loss is even less than the normal recommended range. So in a normal delivery, we say that more than 500 ml blood loss. If it is more than this, then you might need to transfuse. But in dengue patients, even with moderate bleeding, we need to transfuse these patients early. So bleeding is a common phenomena in dengue patients, but in pregnancy, there are more chances of bleeding. Bleeding can be overt or it can be concealed. The overt bleeding can be from any side, but if there is concealed hemorrhage, we must look for the bleeding sites like GI tract, muscles, abdominal cavity, brain, and also look after if there is any placental abruption. There should be high index of suspicion, especially if the vitals are deteriorating despite the resuscitation. And delivery during critical phase may also lead to life-threatening hemorrhage, especially if the platelet counts are very low, and they can worsen the dengue shock due to hemorrhage. And antepartum hemorrhage and postpartum hemorrhage may lead to maternal mortality. So early transfusion is required in these patients. Mild bleeding, it usually does not require blood transfusion, but if the source of bleeding is identified, we must attempt to stop this bleeding by repairing the genital tract injury if there is any. And the transfusion is warranted once there is bleeding and the hematocrit might not be very low. So anticipate the bleeding, arrange for the blood, and transfuse early. You also need to ensure that there's complete removal of the placenta and there are no RPOCs left. And we need to prevent the postpartum hemorrhage because there are more chances of postpartum hemorrhage, and it has been documented in the literature that antepartum hemorrhage and postpartum hemorrhages are one of the dreadful complications of dengue in pregnancy. So we can commence an oxytocin infusion or consider a misoprostol for these reasons. We should be avoiding intramuscular injection and steroids as in other cases of dengue, even in non-pregnant states. The dengue usually requires a high dependency unit care, but sometimes we need to refer the patients to an ICU, especially those patients who require respiratory support for emergency or elective intubation and for supporting the gas exchange to reduce the metabolic cost of breathing. In the post-delivery care, we should be strictly observing the vitals and monitor if there is any bleeding or postpartum hemorrhage. We also know that there is risk of transmission of dengue through a vertical route, although it is not the main route, but the risk of transmission is high when there is very less time difference between the onset of the disease and the delivery of the baby, especially within a week. And we also need to sometimes evaluate baby for congenital dengue. Breastfeeding is not a contraindication. So if pregnant females have dengue, they can continue to breastfeed, although there is one report of transmission of dengue to the baby via breast milk as well. And I think the way forward, as we are talking from 13th till today, in every session is an established, efficacious, and safe vaccine, which can prevent dengue in our patients. I would here like to acknowledge my team members, which are all senior gynecologists and obstetricians of the country, intensivists, anesthetists, pediatrician, neonatologists, and two external reviewers, Professor Hasita Tessera and Professor Lucy Lam, for contribution to these guidelines. We've published these guidelines at a national level. They're available online. You can find them on the web. And if somebody is interested, I have few hard copies with me too, so you can take them from me. Thank you very much. I'll be happy to take any questions.